Let's hear a word from this episode's advertiser. Chemotherapy can damage bone marrow, specifically hematopoietic stem cell and progenitor cells, the source of all blood cell lineages. Learn more about the myelosuppressive effects of chemo and an FDA-approved therapy at www.chemomyelosuppression.com. You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Cyndy Simonson, Oncology Nurse Practitioner, who is the Nursing Editor at Duke Regional Hospital in Durham, North Carolina, and member of the North Carolina Triangle ONS chapter, to discuss biomarker testing for patients with cancer and how it affects targeted therapy regimens during treatment. The advertising messages in this episode are paid for by G1 Therapeutics, Incorporated. Thanks for joining me today.
Oh, it's my pleasure, Stephanie.
So to start us off, why is targeted therapy such a promising treatment option, and what patients are eligible for these treatments?
Well, targeted therapies have already shown in multiple studies that when they're used for the right patients, patient outcomes are definitely better. And, it's the wave of the future. There are new targeted therapies coming along, every 5 or 10 minutes, it seems like. So they're not the only way treatment is going to advance, but they're an important advancement in treating our cancer patients. Patients that are eligible for the treatment gets complicated sometimes, but just a broad overview of that means that patients need to be tested to make sure that they have a biomarker that's appropriate for a treatment that targets that biomarker. So patients need to have been tested in some kind of way, either through sampling of the tumor tissue or perhaps the DNA in the plasma of their blood, so a liquid biopsy or a solid biopsy, to show that they actually have a biomarker that is actionable, and that means that there is a treatment directed towards that biomarker. Those are the patients that are eligible.
Okay, thanks. I think you are right about new treatments coming out every 10 minutes. It is just absolutely astonishing how quickly we are seeing new treatment options, whether they're completely new drugs or if they're just new indications for ones that are already out. And, that adds a whole nother complexity to things for nurses and knowing and being able to keep up to date on what these new therapies are.
Exactly. And it's just like an alphabet soup, alphabet with numbers thrown in. You could throw the alphabet in a hat and throw some numbers in, shake it up, throw it up in the air. And I know 10 combinations of the letters and numbers that would land on the floor would be some targeted therapy. It's hard to keep up.
That's so true. So one of the things that you just mentioned was biomarkers and what makes patients eligible for some of these targeted therapies. So can you define biomarkers and biomarker testing for us?
I'll try to do that for you. Really, technically, a biomarker is any indication of a person's health. Change in weight, fever, blood pressure, any lab results, the stuff we normally assess on patients now are technically biomarkers. But of course, in this discussion and in oncology now, what we're talking about is some biologic molecule found in tissue or blood or body fluid that can be measured and actually provide some diagnostic, some prognostic, some predictive information about a disease, not just Biomarkers aren't used just in oncology, but certainly it includes malignancies. So these biomarkers are produced by cells or tissues in response to a tumor in oncology. And they can include things like hormones, enzymes, glycoproteins, oncofetal antigens, receptors on a cell, as well as changes in tumors such as genetic mutations, amplifications. You've probably heard of fusions, translocations. So it's all of those things about an individual tumor and what is making them become malignant cells and what is driving, you hear that term, driving the growth of the tumor cells. Those are biomarkers. And the biomarker testing too, that's almost an umbrella term. The terminology has changed over time, and I think biomarker testing is more of an umbrella term for genomic profiling, somatic tumor profiling, molecular profiling, and not exactly the same, but you probably lump into their next generation sequencing as well. Those are all biomarker testing.
That is something that is, like those new therapies, just an area that is growing by leaps and bounds. And as the bench scientists are looking at these tumors and the tissue or the liquid biopsies that they're getting, just in how much information they can get out of that to then help determine treatment options for patients, or what direction that diagnosis might go in based off of what we previously knew about these different oncology diagnoses.
Oh, exactly. And, we think of prostate cancer back in the day, you just didn't even think of markers for prostate cancer. And now there's, multiple markers. Prostate cancer has CHEK2, RAD51D, BRCA1 and 2, MSI, MLH1, ARV7. I mean, there's more. And that's all fairly recently that you would even check a prostate cancer for any biomarker other than PSA and figure out whether to androgen suppress or not. And goodness gracious, think about non-small cell lung cancer and the myriad biomarkers you really need to check now to really figure out how to appropriately treat the patient. Whereas, long ago, or in particularly, I've been an oncology nurse practitioner for 42 years. We just gave you cisplatin in the beginning. It's just very different now. And it's not only the tumor, but you also, the ethnicity of a patient plays into one of the biomarkers commonly used for non-small cell lung cancer. 50% of Asian patients will have an EGFR mutation and only 10% of Caucasian patients. So it's complicated now. There's a lot that goes into understanding a patient's individual tumor and what is making it or driving its growth, and how can we target that part of the tumor to get a better response for patients.
So you've talked a little bit about, the different cancers that have some different biomarker testing, but can you just talk about the actual process of biomarker testing with patients with cancer? And then how do the results of that guide the clinicians and their decisions?
Well, I'm going to start maybe further back than you think I'm going to in the process of biomarker testing. And you alluded to that in something you said just a little bit ago, and that is the researchers trying to find the target. That's really the first step in biomarker testing is the bench researchers who are really actively looking in every tumor type for what the drivers are, what the biomarkers, what the gene mutations are, and is there any way to target those things. So it's the research at the bench and then the clinical trials going on to try to help us identify biomarkers that are really actionable. I'm not going to say it's easy to find biomarkers, but just a very common biomarker in my colon. I'm specialized the longest part in GI cancers, and KRAS is an important biomarker in colon cancers, as it is in many others. It's a very common signaling pathway that drives the growth of cancer cells. And for a long time, researchers have tried to come up with something that targets KRAS in an effective way, and they really haven't until just recently. They're starting to make some progress in actually being able to effectively target the KRAS biomarker. It's such a part of the signaling pathway that's close to the top of the signal, so that if you block it, there are lots of ways for the tumor to go around. And so, after years of research, they're just beginning to find some effective ways to target the KRAS that's driving a lot of colon cancers. And so that's number one. You have to actually find a biomarker that is targetable, that you can actually block or treat or interfere with in a way that substantively impacts the growth of the tumor cell. Another example is like in cholangiocarcinoma. Again, for years, no really good effective treatment and certainly no biomarkers. But now there are two that have been really identified, the FGFR and the IDH1 and 2 biomarkers. The FGFR is really a driver of the growth of the cholangiocarcinoma. And so that's been targeted with pretty good response. The IDH are not necessarily drivers of the cancer cell growth. They are more involved in the metabolic processing of tumors in just a way that helps support the growth, but maybe doesn't really drive the growth. So in the cholangiocarcinoma, the IDH1 and 2 inhibitors are effective, but maybe not as much as the FGFR that really targets a driver of the cancer cell growth, and maybe for not as long as the other drivers. So you have to find an actionable biomarker, and then you really want to try to find them that are main drivers of the cancer cell. So it all starts back in research. Now, we've got that. The next thing is you have to identify the right patient for the marker. So a patient who's diagnosed with cancer, you really do these days want to do biomarker assessment. I think a lot of people now just turn to next generation sequencing so they can look at a lot of things all at the same time. And there are lots of different companies that do that. So you've got to research needs to identify our targets and develop ways to treat them. And then we need to find the right patient. So that's the next step. Either liquid or tissue, or perhaps both, need to be tested so you can see if there are drivers for that person's cancer that you actually have a target for. Then providers need to really be knowledgeable about how to order them. There are lots of companies. Some do tissue sequencing, some do liquid biopsies. You need to know which one is better for that cancer, maybe in that patient situation. Maybe you want to do both. Some people just do solid. Some think liquid is better. Some do both. That's provider based on the patient they're looking at, the tumor they're looking at, what they know about, what they think is the most effective. So you've got to order it. And so to order it, you have to know, does your institution have the infrastructure to do the testing, or do you need an outside company that you're going to send it off to? And then you need to choose your company. And then you need to really know how that company operates. So you order effectively, you're set up in their system correctly so that results come back to you in the most easily recognizable manner and in as timely a fashion as possible. And then once you get those results back, you need to understand how to read their reports and figure out what biomarkers you're seeing that may be positive, and then which ones actually have an actionable treatment. And then after you identify those things, then you need to figure out, well, actually, we've missed a step. You need to figure out before you send it off if your patient's insurance will cover it. And that's getting better as we go along, but still not all insurances will cover this kind of testing for every single tumor. So you need to figure that out for your patient first. And then you need to figure out if the treatment that might be available for that biomarker will be covered by the patient's insurance. And again, that's getting a lot better these days, but still something that you need to look at. And then you can treat the patient with the targeted therapy. How's that for a long-winded answer?
That was great. But that was a really good explanation of how that goes. And, as you were talking about that, one of the things that I was thinking about was even just within the last 5 to 7 years, it seems like patients that were at large academic centers, this might be something that was easily or routinely done. But maybe patients who were in more rural settings might not have this done as early as it should be done or something. So do you think, as you've been talking about, you have to know where to get the testing done, if patients are in more rural settings, do you think that this has become pretty commonplace that if they are having a biopsy done, let's say, there's something suspicious and they're having a biopsy done, that those biopsies are initially being tested routinely, or that's still not quite the case?
I think, unfortunately, it's still not quite the case. It's certainly more common than it has been. And I don't even think it has to be necessarily in rural areas only. In getting ready for this podcast, I did a little bit of reading, and there's a pretty good study from 2020 that shows even in community practices outside of academic practices, the penetration of reflexively or automatically or commonly ordering this kind of testing is not where it should be. I think I even saw like an 8 to 10% of patients get it done automatically when it should be a lot higher. There's some clinicians who think it should just be ordered for every patient now from the start, even though you may not use it in an earlier stage patient. There are situations, again, like with colorectal cancer, that for an earlier stage patient, you want to know whether they're MSI high or not, microsatellite unstable or not. Those are things that tell you a patient might respond really well to immunotherapy instead of chemotherapy. And you want to know that in an early patient, whereas most of the other biomarkers you might get for colorectal cancer patients, you may not use until it's later stage or metastatic stage when some of other treatments have already been tried and stopped working. So yeah, I don't think it is as common. And maybe that's to do with the earlier lack. It was really difficult early on to get insurance coverage. And that has gotten better and better, though not perfect. So I don't know if that plays into it, but no, it's not quite as common as it ought to be everywhere yet.
Yeah, that's really interesting, the article that you found and the results of that. And you would think that now that should just be something that's kind of that initial testing. And that brings me to my next question, which is, when should biomarker testing be done? And what should the nurses do with the results?
Well, that's a complicated question again. When should it be done? It depends on the tumor and whether there are actionable markers or not. But I think a lot of clinicians in practice who do use this testing tend to order it almost from the beginning, and that gives them a chance to see if there are actionable markers that might be useful in the beginning of treatment, if there might be some germline markers that would indicate genetic transmission so that a patient's family members might need to know about what's driving the tumors, and they perhaps should go for genetic counseling. So being able to do it from the beginning is helpful. That doesn't always mean that by the time you've used earlier treatments and you're ready to maybe think a target that you found in the beginning is actionable when the tumor has progressed or developed a metastatic disease. You may need to retest the tumor because things genetically may have changed in that tumor, but it's still probably helpful to get it in the very beginning. A patient that might not need testing, although that's even in these days, that's hard to say, but maybe a patient who comes to you that is really advanced and does not have a good performance status, maybe that's not a patient that you need to concentrate on doing the biomarker testing right away for actionable treatments, though. And that being said, in this day and age, if it was a patient that had an NTRK fusion, even though it's a very small percent, those patients that do have NTRK fusion genes, they have really tolerable treatment that works really well for them. And, so it's hard to say, but that would be my thought about patients who might not be treated or might not be really right for testing. So, but it may be testing in the beginning. It may be tumors that only have targetable things when disease is more advanced or progressed. So you may not test at the very beginning. You may test in the middle. Now, what do nurses do with the results of those different nursing roles? It's really helpful to have nurses who may be following for the results, making sure the testing gets done in the right way, gets sent off. And when the results come back, you help make sure it gets to the provider who's making the treatment decisions, and they can really see if there's actionable treatment. And a place that this is complicated is sometimes, speaking from the academic perspective, when you do get a second opinion from someone coming from the outside, tracking down whether they've actually had the testing done and where the results are so that you can use those results rather than repeating. That can sometimes be a very important thing to look at from the beginning and work on. And then these results can be so complicated. I'm not sure a nurse should feel like they need to understand, I certainly don't, all of it now. But when you do get the results back, it is great to try to understand what those results mean, because we know nurses are the main educators and supporters of patients. So being able to understand what that patient's results mean so that you can really help explain to them. And you may be explaining to them that they do have an actionable biomarker that there's a treatment for, but you may also be explaining to them that though they have some biomarkers that are positive, there's no actionable treatment for those biomarkers. So it's just really great for the nurse to help in that way too.
And now let's hear a word from this episode's advertiser. There's a way to help protect hematopoietic stem cell and progenitor cells in the bone marrow against the harmful effects of chemotherapy. To learn more about an FDA-approved therapy, visit www.chemomyelosuppression.com. How can oncology nurses work with other members of the interprofessional cancer care team to facilitate biomarker testing?
I think knowing what your institution's infrastructure is for biomarker testing. Is there a box that when someone who's ordering the original biopsy on a patient to diagnose them with cancer, do you have reflexive testing? There's a little box where you can check, yes, go ahead and send this out for biomarker testing from the very beginning, and encouraging whoever that biopsy or might be to do that. If you don't have just automatic testing, then, following up with the pathology report and getting the ordering provider to figure out whether they need to order the testing on that tumor sample once the biopsy is back. I think those are important things to do. Like I just talked about earlier, if you're in a nursing role that can help make sure that the sample gets sent out appropriately and to the right place, that can be very helpful. Maybe you're in a role that can really help watch for the results to come back and get those to the right people. And then even things like you may be the one who actually interfaces with the outside company that might be doing your testing, and can you go ahead and get set up online in the computer with that company so that you can get electronic results back quickly and in a way that's easy. You're not watching fax machines for the results to come in. That just getting set up with the company that you institution or your provider uses and is the most comfortable with, really get set up with that company, and that just smooths things out. And then, being the patient advocate too for getting testing done and getting results explained, and, just the nursing that we do with our patients. Those are the ways I think nurses can help move things along and make things happen in a good manner.
Yeah, I think it's really important that nurses understand what they do have available, like you said, at their institution, and are aware of, and then just know how to read those results, because they can be very, very confusing, or have a really good mentor or someone that they can sit down and talk through just to completely understand that. Because as we know, the patients are going to be asking the nurses about those results and probably asking them to try to help them understand them a little bit more. So it's really important.
Exactly. I partnered with one medical oncologist for a long time that I just loved, and he's great. But how many times did he go over everything with the patient, what their cancer was, what their treatment was going to be, and he stepped out of the room and they looked to me to say, what did he say? And so it is helpful if we understand what he said too, so that we can explain it to the patient again.
Exactly. So let's say a nurse has a patient who asks them about biomarker testing and whether it's right for them. What's a good way for the nurse to respond?
I think to help the patient understand the potential for biomarker testing, that it can be a really good way to identify how their cancer grows and to see if we have a treatment that could impact that particular way the tumor grows. I think it's important to explain that to the patient. Sometimes it's important to understand whether the testing should be done at the beginning or whether it is something that will be done later on. That may help a patient who may not be appropriate for sequencing at the very first biopsy, but let them know it's something that may come into more importance later on. And then I also like to be sure from the beginning that the patients understand that we might find something that helps us decide on their treatment, but their results might come back in a way that they don't have something that helps us decide treatment. I think that's important for nurses to explain to patients as well.
Yeah. And even in that question that I had just asked you, if a patient wouldn't ask you that, let's say, but they're already, they've had their biopsy done and things like that, and maybe testing hasn't been done yet. What would a nurse, or how would you respond to them, at that point? Because sometimes when the nurses are involved, or by the time the patient asks that question, they may have already had that biopsy done. And so what would you say at that point to them?
Yeah, that's where you want to be your patient advocate. So whether it's a situation where you can be back to that provider to say, why aren't we looking at this? Or can you explain to me if this is right for this patient? or not, and whether we should go ahead and get this ordered or not, or if it's a situation where you should advocate for your patient to go back to their ordering provider and ask, is this something that should be done on my tumor, and might this help me, and how might it help me? So depends on exactly the situation, but yeah, it's your patient advocacy skills then when you recognize that it might be good for the patient to be back to the provider asking for it to be done, or asking the patient to advocate for themselves.
I appreciate that. I think that's a really important thing to know because, you've mentioned a couple of times about how with certain diagnoses, even if you don't use that biomarker testing at the very beginning, let's say, but if you have it and then later on they end up with metastatic disease and they do some testing at that point and they can compare those two, you can see where the benefit would be to having that testing done at at that initial diagnosing stage, and how it can be valuable, or how you could see that there might be some change in the tumor when it does metastasize.
Exactly. And that may help you, skip past a treatment that you might have thought was going to be effective for the metastatic disease, but now you can see that driver, that tumor has completely mutated, so it won't be responsive to that treatment anymore, and you can move on to the next. Or also importantly, look for clinical trials. Even if there's not a commercially available treatment for that target, there may be a good clinical trial. And if you have that information already, you can save a lot of time in the enrollment process for a patient who might be eligible for a clinical trial that's targeting that biomarker. So that's an important part of the process as well.
That's a really good thing for our listeners to understand, especially new nurses that are coming into oncology, and just understanding why that is an important thing, to look at when you're looking at your patient's records. And, even if you don't have to do anything with that, but just to get yourself familiar with those different testing results and things like that, but just how important it can be across the continuum of treatment for that patient. So you have had so much great information for us today, and really helped to understand how biomarker testing is done, how it's used, and the importance of it, and how much it's changing, how quickly it's changing. And I really appreciate you being with us today and doing that. But before we finish up, I like to end all of our podcasts with a few questions. And the first one is, what are some common misconceptions about biomarker testing and targeted therapy?
I think it's such an exciting part of treatment now. We see the FDA's approved this is on fast track. Now there's a treatment for NTRK, there's a treatment for MET, there are all these different things, but I think it's a common misconception that everybody's going to have an actionable biomarker. And not to be a Debbie Downer, but really it's a small percent of patients that are actually going to have a targetable biomarker right now. Even if you think of non-small cell lung cancer, and one of the main biomarkers is ALK, and it's only 3 to 5% of those patients that are actually going to have that biomarker in a way that it can be targeted. We hear a lot about the BRCA1 and 2. At first it was just breast, but now it's also ovarian, pancreatic, and prostate. But even when you include breast, it's only 5 to 15% of patients that are going to have that marker. And like the NTRK fusion gene across all solid tumors, there's only 1% of solid tumor patients that are going to have that NTRK. Now, if they do have it, it's very treatable, but it's very common in a few rare cancers, in infantile fibrosarcoma, secretory breast cancer, secretory salivary gland carcinoma. But across most tumors, it's not very common. So they're very exciting advances, but it's still not going to apply to as many patients as we wish it would.
That's good and important to know. So what's something about biomarker testing and targeted therapy that's not often discussed, but you wish more people knew about?
That it's available and potentially helpful in treatment decisions, and sometimes really important in treatment decisions. There's in colorectal cancer, in some of the late stage metastatic tumors, if a patient was treated with an anti-EGFR therapy, but they had a KRAS or an NRAS mutation, that anti-EGFR therapy may actually be harmful to them. It may actually make the tumor grow more. So I think it's important to really understand the ins and outs of how all this targeted therapy fits together, and make sure you know what you're doing when you're treating patients.
Thank you. So what additional training or resources about biomarker testing and targeted therapy should oncology nurses have access to?
I think access to resources that will help them understand it. ONS has good resources on their website, and also NCCN has good resources. I like Dr. Neil Love's Research to Practice. He has a lot of physician-oriented education, but he also does some really good nursing education. So ACS and National Cancer Institute's website, they all have really good information for nursing and also for patient education, which is a good way that I educate myself on things that I don't know about. Sometimes I like to start with a patient education and go from there. So I think hitting up those websites.
Great. Cyndy, thank you so much for being with me today and for all of your expertise and knowledge in this area. I think it's going to be an extremely helpful podcast for our listeners to really kind of increase their awareness, and then also hopefully start them thinking about looking at this a little bit more, what their institution does, and looking at patients' charts to start seeing if folks have had testing done and just understand it more, because, as we said at the beginning, this area is just growing by leaps and bounds and impacting treatment so much that it's going to be, need to be almost second nature, for us as clinicians and working with our patients to understand and be able to help explain to our patients and advocate for them as this area just continues to grow. So do you have any final comments for us today?
No, I completely agree with you. We know that these targeted therapies improve patient outcomes and in a lot of cases decrease toxicity. So it's important to know how to use them and how to combine them with our current chemotherapy regimens to improve the effectiveness of those regimens too. And I thank you for inviting me. I've really enjoyed visiting with you today. I appreciate it.
Thank you. And now let's hear a word from this episode's advertiser. Learn more about protecting the bone marrow, the source of all blood cell lineages, from the damaging effects of chemotherapy at www.chemomyelosuppression.com. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.